So let's look at the chamber combinations. I open the heart on the right side, and you see that we're dealing with a morphologically right atrium, pectinate muscles going all the way round the atrioventricular junction, that is joining into a morphologically left ventricle. Smooth septal surface and fine crisscrossing apical trabeculations telling us this is a morphologically left ventricle. And as we expect, it is a morphologically mitral valve that is guarding the right-sided atrioventricular junction. But when we look at the arterial trunk that is arising from this morphologically left ventricle, we find that it is the aorta. So the aorta is arising from the morphologically left ventricle. But there is another unusual finding, because you see that here there is muscular tissue that is producing discontinuity between the leaflets of the aortic valve, the leaflet of the mitral valve. So although this aorta is arising from the morphologically left ventricle, it is not doing so in the usual fashion, because typically we find fibrous continuity between the aortic valve and the mitral valve. You'll note that there is also a ventricular septal defect, but what we see on the right side of the heart is the combination of discordant atrioventricular with concordant ventriculoarterial connections, so that the systemic venous return is going back to the body. We see that the left atrium is left-sided, smooth walls, morphologically left atrial appendage arising from the left-sided atrium. We see the left atrium is then going through a morphologically tricuspid valve into the coarsely trabeculated left-sided morphologically right ventricle. And we can also see very nicely that this right ventricle is showing us left-hand ventricular topology. It is the palmar surface of my left hand that goes on the septal surface of the right ventricle, with my thumb in the tricuspid valve, my fingers in the outlet valve. And the outlet valve is a pulmonary valve, because here the arterial trunk arising from the morphologically right ventricle is the pulmonary trunk. So that we see discordant atrioventricular but concordant ventriculoarterial connections, so the pulmonary venous return is being sent back to the lungs. So here we have the hemodynamics, in fact, of regular transposition. The systemic and the pulmonary circuits are in parallel rather than in series. Now this is an interesting heart with discordant atrioventricular connections, because it is this small subset of patients with the combination of discordant atrioventricular and concordant ventriculoarterial connections that are the perfect substrate for the atrial switch procedure, because if these venous returns are transposed at atrial level, then the morphologically left ventricle is left in its appropriate position, pumping the systemic circuit. But the feature of this heart is that when we look at the level of the ventriculoarterial junctions, we see that both of the arterial trunks are arising from the morphologically right ventricle. The morphologically right ventricle, unusually in this setting, is itself hypoplastic. It's connected through the morphologically tricuspid valve into the morphologically left atrium, but here discordant atrioventricular connections with double outlet right ventricle. The typical feature of double outlet right ventricle, as seen with discordant atrioventricular connections, is that the aorta is anterior and leftward relative to the pulmonary trunk. In this instance, the pulmonary trunk, in fact, is grossly hypoplastic, and this is because the pulmonary valve itself is imperforate, although it is connected to the morphologically right ventricle. Now, interestingly, note that the apex of this heart is pointing leftwards. During life, almost certainly the larger part of this heart was in the left side of the chest, suggesting that we're dealing with a usual arrangement. But in fact, that is far from the case, because when I open up the left-sided atrial chamber, you see it is a morphologically right atrium. Coming into the heart here, we have the superior caval vein, we have the inferior caval vein, and here we have a coronary sinus. We have the oval fossa on the surface of this atrial chamber, and we have a morphologically right atrial appendage with pectinate muscles extending all the way around the atrioventricular junction. So we have a left-sided morphologically right atrium, and when I turn the heart over to show you the other side, we have a right-sided morphologically left atrium. Here are the pulmonary veins coming into the roof of the atrium. Here we see the opening of the morphologically left atrial appendage. There is a typical morphologically left atrial appendage, narrow and crenellated, and we see the predominantly smooth walls of this left atrium, with here the left side of the oval fossa. So we have mirror-imaged atrial arrangement. But then, when we look at the atrioventricular junctions, we see that this right-sided morphologically left atrium is connecting through a morphologically tricuspid valve into a coarsely trabeculated ventricle. And now this time, when I show you the topology of this ventricle, you see that it is the septal surface of my right hand that goes, or rather the palmar surface of my right hand that goes on the septal surface of this morphologically right ventricle. And you can clearly see that the arterial trunk exiting from this right ventricle is the aorta. So here we have discordant atrioventricular connections, left atrium to right-sided right ventricle. We have discordant ventriculoarterial connections, the right-sided right ventricle giving rise to the aorta. When I turn the heart round, again you see double discordance. The left-sided morphologically right atrium is connecting through a mitral valve into the left ventricle, smooth septal surface, fine crisscross apical trabeculations, and arising from the morphologically left ventricle, we have the pulmonary trunk. Discordant atrioventricular connections, discordant ventriculoarterial connections. But now, when we look at the relationship between the aorta and the pulmonary trunk, we see that the aorta is anterior and right-sided. We have detransposition, even though the detransposition is congenitally corrected. There is one other fascinating feature here. We can see the ventricular septal defect, typically here, opening between the limbs of the septomarginal trabeculation. We can see that the muscular outlet septum is deviated posteriorly, and the muscular outlet septum is narrowing the outlet into this pulmonary trunk. So we have a malalignment ventricular septal defect producing pulmonary stenosis in the setting of congenitally corrected transposition with mirror-imaged atrial arrangement.